Such a great attendance. But I think I want to touch a little bit. In 1988, I was fortunate that I was in a meeting and I met Professor Kellett. We became very good friends, and I went to see him. And I think the society has really recognized very much what Henrik has done for all these years, has inspired all of us. And this was a dream that would happen one day, and this is actually happening. So saying that, thank you very much for listening to me. And I'm going to present to you something that is a little bit out of the way. And this will be for surgery, for anesthesia, for everything. I don't have anything to disclose specifically. Now, I think you heard before that 30% reduction in functional capacity after surgery, 15% in cognitive dysfunction, which is not too trivial, and 20% medical surgical complication. This was a painting of an 18th century French painting, La Convalescence. If you actually look, there is a glass of water, the patient is sitting up actually for a change, and look how lost weight and so on. This is happening today. But the reality is that there are definitely a quality improvement in general surgery, and this is coming from the next script. And as you can see, complications is actually a major driving and in colorectal surgery. And we take an example, it's actually coming number one with 25%. So it's not trivial, it's actually first in the general surgery. Now, let me show you this trajectory, because that's maybe quite interesting, is that we're assuming that within the minimal level of functioning, you are at some level, and then surgery causes something, stress response, we call it. And then you have this trajectory of returning, hopefully, to functioning. I would say probably 80% do that. Now, what we have done, we have come up with a fast track. Great, we said all potential elements of this enhanced recovery may in fact do that. Well, basically, the drop will be still there. And we saw the ortho telling us the patient went home, went to rest in bed. And then happened slowly, slowly. We don't know anything what's happening in the recovery. Now, I presented data, and was shown by Mike as well before, that this paper in Annals of Surgery 2011 showed the factors predict complication: age, BMI, COPD. They found alcohol and duration of surgery. And some of the comments will say, it is clear from this data the preoperative health and functional status as well as operative approach contribute to short-term outcome. Now, the contribution, I would say, operative approach with advancing surgery and advancing anesthesia, I think really we've done a great job. This is another study coming, again, JACS, where there are colorectal surgery, 15 variables predicting high risk, non-modifiable, and some are modifiable, and functional status came back again. This is an interesting study a while ago, almost 10 years ago, and they look at the factors for prolonged recovery in elderly population. As you can see, there is nothing to do with creatinine or albumin we're always concerned about, but serious complication, of course, is, we know is a drive. But look at physical performance status, very highly significant, and look at geriatric depression scale, frightening. And this the population is going to increase. Now, this is the study again, Gustafson, elegant study, hemoglobin A1C, potential also indicator of the cases that we deal with, and definitely much more complication in the patients who had an hemoglobin A1C greater than 6.1. Now, how fit are our patients? Now, of course, you recognize those two. The girl is Jennifer Sanson, probably the world class female, and they're talking about 23-24 meds. Probably us will be in the category above 10, I would say, most of us. We looked at 114 patients, do VO2 max, and that's the reality. These were not obese, these were a mixture population of a BMI 27, 26, slightly overweight. Look at the 6.1. Now, a cardiopulmonary exercise tendency is fascinating, I think it's great. Look at the various studies done, and there are more studies, where they actually predict mortality or morbidity based on also cardiopulmonary exercise testing. And this is an exciting area. But can we do it? We heard about it's difficult. It's labor intensive. So we thought of, because the literature is telling us that it could be a good test, is the 6-minute walking test, and we validate it in surgical patients. And the idea is to use a 6-minute walking test, which is standardized. I'm not going to explain, but it's a measure submaximal because we don't work at VO2 max. We don't live at VO2 max. We live at submax. And that's what I think we should measure. And a measure of submaximal functional capacity with all the problems, includes strength, endurance, and morbidity. This is a study done in our place, where in fact we looked at 296 patients, and we do what is the optimal cutoff for 6-minute walking test, which is sensitivity and specificity, which are acceptable. And we found that 392 meters was the cutoff, below which there was an independent risk, increased risk for cardiac respiratory, which will fit with the format or other score test. So can we use that? That's maybe an interesting. Now, this is paper with John Birkmeyer, which probably has done all the work in complication and so on. And he says, suggesting postoperative complications are related more to patient factors than to quality of care. I think we're really reaching a superb quality of care. Now, who are these people at risk? We don't know. We think the elderly, sure. We know that elderly could be, that is not everyone, but definitely there are over 75. Poor nutritional state, we don't assess poor nutritional state. Your surgeon, you're asking, when was the last weight? We don't have a nutritional assessment? No, albumin we have, that's all. Weight loss, some nutritional assessment done by a dietologist. Presence of comorbidity, we heard about, cardiac risk. Obese, rampant, malnutrition, index of malnutrition. Cancer, 60% of our colorectal are over. Think about cystectomies, think about esophagectomy and so on. Depression, it's been shown very well that depression is related to postoperative complication. Anemic, what do we do for anemia? Maybe iron. These are patients with a limited reserve. That's what I would like to talk about, reserve. The capacity to sustain an insult. Now, what about rehabilitation? So this is very much what I'm talking is very much a potential feasibility. And that's what it's my passion at the moment. And to use the preoperative period of time within the constraint we have, and probably fighting or challenging a dogma that the patient has to be operated at all costs. To optimize the physical, nutritional, emotional, medical, and pharmacological conditioning. We heard about the nursing, the education, and so on. And with the intent to improve postoperative functional capacity, we have been talking patient-centered. I think we should consider the patient as the center of care. For patient walking and be able to go shopping and be able to go and play with their friends, probably is more important than many complications, to some extent. And of course, impact on preoperative medical and surgical mobility. Of course we have to do that. Now, so my hypothesis is that if we are able to push up in the green, preparing them, of course we will have this period. We have to work very hard. Is it happening? These patients are fatigued. This is a fact. It's not psychological only. It's a reality. And then the journey starts for rehabilitation. Now, is it possible that we can enhance that and make sure they're actually in function, not going home only, but functionally fit to go back into community? Now, exercise is good for everyone. Exercise prevents disease. Exercise benefit disabled condition. It's evidence. It's all written in there. I don't need to reference. Exercise increases aerobic capacity, ratio, lean body mass, body fat, decrease sympathetic overreactivity, improve insulin sensitivity. And exercise increase mood, reduce anxiety, improve ability to handle stress. Now, this is a very elegant study, longitudinal study, New England Journal of Medicine, 2002. As you can see, whether you have a normal subject or cardiovascular disease, if you are 5 meters, 6 meters, remember our patients were around less than 6 meters, that the survival at 14 years is definitely reduced. For each 1 meter increase in exercise capacity, we confer 12% improvement in survival, 12%. Excellent work. Now, this elegant study shows how exercise. They take sedentary older patients and they're randomized to aerobic exercise group, supervised 3-day elderly patients, or control. And then 1 month, we gave a punch biopsy in the upper arm. And then they look at the wound healing. And there was almost 10 days difference between the one who actually did exercise, they healed first, better, first. This is also an interesting review from Journal of Alzheimer for cognitive aging. Now they look at 4 core major lines of evidence: epidemiological, animal, human proof, and RCT. And they look at all the different factors, the size, Sudoku, and cholesterol stating, ginkgo biloba, and so on. Consistently, all studies, exercise and intellectual stimulation can consistently beneficial to cognitive. Now, let's take a look at what actually has been done on rehabilitation. It's very novel, of course, concept in surgery, but there's been some studies, and I've been able to find something. This was the effect of preoperative inspiratory muscle training on pulmonary complication after cardiac, and we know how important it is, and there is evidence that generally benefits. But then we go on preoperative exercise in joint replacement. Yes, we have some evidence, more in knees than hip, mainly in terms of rehabilitation at home. And the last one that I found is a PhD candidate in exercise physiology in Canada. And he sent me this picture, the way I actually look what is available. And you see it's very few data on visceral. And it seems to be there is something there which favors the treatment of preoperative exercise. So we're still navigating very much into the unknown because we have a very little data. So I'll tell you a little bit of our experience, and very limited, of course, but it's to make you thinking, mainly, like happened to me. We took a pilot data. We looked at 28 patients, pre-ab, control, low fitness, 55 years old, BMI of 26, and we decide home base is the best. They can't come to the hospital, it's too expensive. 7 days a week, 45 to 65 heart rate reserve, bicycle, VO2 max, and then go to the maximum. Exercise compliance every day there to do it. We found that 4 weeks was sufficient to a 50% of VO2 max, which means there's an increase of between 2 to 3 meds. So from 5 meds, they can go up to 8, and we know that may help them. And there was no change in the control. So we decided to do a randomized control trial. And we looked at 112 patients randomized, and 2 groups where we actually did intense exercise, biking, strength program, 30 minutes with an exercise physiologist, home. At the control, we have a very basic recommendation to ankle movement and respiratory and walk. 4 weeks before surgery, no postoperative program. We want to see whether before there was anything. And we look at functional walking capacity, 6-minute walking test, and all the other measurements. And with our great surprise, we found actually if you did exercise, intense exercise, the patient actually deteriorated. And there was extremely low compliance, 38%. The one who did not very much, I mean, in terms of control, they didn't change very much, very little, but they did slightly decrease. So they were predictors of poorer recovery, the complication of course, the age. So then what we found out from the journals, because everybody had a logbook, we found in fact that the one in the control group, were actually doing exercise because it's a behavioral study. It's not a placebo with a one tablet. So people say, oh, if they do the study, we might probably going to be better. So when we look at all responders. And we look at those who improve in the pre-rehabilitation period, the green one, they actually staying above and they remain higher. The one that didn't change, a third did not change very much, as you can see, but the one who actually dropped postoperative was the one who actually had, during the pre-rehabilitation phase, actually dropped postoperative and had more the complication. So this is basically gave to us an idea that the potential predictors were complication, age over 75, and also moderate anxiety, high anxiety. So we were intrigued that the high probably exercise, intense exercise, was actually not good at all. So despite the exercise 1/3 deteriorated and poor compliance was probably too intense. Patient did not want to do it. So we decided that, we didn't control for nutrition. And we know these patients are cancer patients, many of them are IBD. So we know they're potentially malnourished. We didn't control. And also we found that 25% of our patients were extremely anxious and depressed. So we said, why don't we put either element? And the element was to reduce the anxiety, to go with a moderate exercise. And then we looked at the control, historical control we had just months before we finished. We took 45 patients, and we had all the assessment, same assessment in functional capacity. And we took only the colorectal cancer only, and we do very much an observational studies. They're all treated with ERAS, like the previous other patients, and the outcome was functional outcome, capacity. So the exercise was at-home exercise, 50% of maximum heart rate reserve. We didn't do VO2 max, we just calculated. And then we increased by 10%, 20 minutes, and with resistant exercise. Tear bands or weight if they had at home. If they want to do swimming, they could do swimming or walking was sufficient. And then counseling, we look at the counsel, we look what was sufficient then when you increase with whey protein. And the other stress reduction was intervention, very much in terms of anxiety, imaginary tape to do at home. Now, which physical activity, and as you can see, is quite a moderate activity. We gave a booklet of visual instructions. They knew exactly what exercise to do. A logbook to record the physical activity and a heart rate monitor. And the exercise were as indicated there. Now, why we chose whey protein? Because first it's extremely highly digested. There's a quite good work where in fact whey protein, because they contain essential amino acids, particularly leucine, incorporate into muscle and they increase the muscle protein synthesis, particularly if you have immediately after surgery. But not only that, what was interesting is that they contribute to increase GSH, as you probably know, glutathione synthase, which is important. And as you can see after surgery, there's a huge drop in GSH. Now, we gave whey protein because look at the study. This is milk compared to soya. Look, the increase in leucine incorporation is in the muscle is very high and is immediately within the next 30 minutes. That's why you know if you go to the gym or you do exercise, always have a meal immediately after, within the first hour, because that's you incorporate the maximum in protein synthesis. And here we have the result. The results, what we found that the patients who were in the rehabilitation multimodal increased during the rehabilitation period by an average of 40 meters. They dropped in the first 4 weeks, as you can see, but still was a not significant difference, slightly different from 4 to 2 the previously, and then they increased up to 8 weeks over the baseline. While the one who didn't do anything, as you can see, they were dropping. Unfortunately, we didn't have any data, but we have more data now, which consistently show that they drop, and then they drop postoperatively, and they remain low after surgery. So even using the 3-model concept, you definitely can do something about it. Now, we don't know exactly whether the nutrition is probably better than exercise. We don't know, or the psychological aspect. So what we did, we gave a questionnaire and said, well, what is your report of self-activity? And in fact, the one in they increase the activities and remain high after activity. And it talks about we use a computer, you do gardening, and all the activities, and calculating in energy expenditure. So we have an idea that potentially this patient, they did something, but smart work to do in terms of quality and quantity of work. Now, compliance. I just put the slides because we just calculated the compliance. We're talking about 62% of compliance. So based on the report, we have to improve, of course. We have to know exactly what the patient do. It's all work in progress. Now, because I'm sure surgeon will ask a clinical outcome, I just want to show basically we didn't see much difference, but it's a small group. We are talking about 40 patients. So I don't want to go and say there isn't. Let's have a look. Definitely we know there was an increase in functional capacity. For the patient, could have been important that. Now, so we put all these together, and we said, okay, this is the rehabilitation colorectal, the RCT, and the 3-model. So we have the control group. As you remember, recommend walking very little. The biking, intense exercise, and then trimodal, where you have moderate, and then you have white protein or nutritional anxiety reduction. 3-modal. So that shows you during the rehabilitation, the length of stay at 8 weeks postoperative, the biking was the worst. The control didn't do very much. The 3-modal was together was the best in increasing functional capacity. Now, what is the next? Because it's all work in progress. It's all feasibility. I call feasibility. It's definitely probably we might identify that frail patients, frail one, may in fact benefit, and the one with more invasive surgery, and patient with high hemoglobin 1C. We don't know. That could be a very interesting aspect. Or patient going for chemoradiation. It's a major insult. And also procedure specific. Now, I want to show you what we did. We did a quick analysis just before coming, and we look all the 3-modal. And it's interesting, if you look at the rehabilitation, 6-minute walk increase. In the patient who, I remember the cutoff was 392. But basically, we looked at is 35%. So potentially there's 30% of population or really are below the cut. Potentially they're at risk of cardiopulmonary complication. Look at the increase, the 6-minute walking much higher than 40 meters as we saw on average. So potentially this could benefit, and we know lower reserve you have is easy to push up. But interesting, look at the patients who were 60% below predicted of 6-minute walking test. We have same result, 35%, 33%. Increase of 53. But interesting, they're all over 70. So we identify potentially patient, but of course these are only 66 patients. We have to increase it. So rehabilitation is feasible. It's a team approach, like ERAS. And exercise alone may not be. More work to do. Potential to modify perioperative risk, that's open. Makes sense, of course. But what I think we're missing all this knowledge that we have from physical exercise physiology, nutritional, behavioral, applied to perioperative pathophysiology. All these people working in exercise physiology, they're all working on healthy people or COPD or cardiac. We don't have any data on cardiac, on surgical patients. And a program like perioperative should be really part of the ERAS. And that's why we did it, because ERAS gives a list we know that is within a very integrated evidence aspect. Now, I want to really thank you very much. Many of our surgeons, colleagues are here with me today, and really they've been my department of anesthesia, which allows me to use the corridor of this patient walking up and down. This is really, truly effort, but has to be really a team. And I don't know, might be the future. We'll see. Thank you very much.